Hello, this is Dr. Yanish. This video is going to be a single incision endoscopic carpal tunnel release. The surgery starts as usual with the marking of the skin incision. This is done just around the distal wrist crease. The markings are then wiped off with a damp sponge so that they are just barely visible. The anesthetic is tested with some forceps to make sure that the patient is comfortable and does not feel anything sharp. Once we've confirmed that the patient is comfortable, skin is incised with a 15-blade scalpel. Notice that a very small incision is made, usually around the length of 1 centimeter. The dissection begins with some Littler scissors, and the dissection is taken down to the antebrachial fascia. The incision is then held open with a Ragnell retractor and a skin hook. This opens up the incision slightly so that I can better see the deep tissue. Bipolar cautery is used to cauterize the visible veins. A small piece of fat is removed here to allow better visualization of the antebrachial fascia. And similar bipolar cautery. The antebrachial fascia is then gently opened with the scalpel, just allowing access to the nerve, which is immediately below this level. This is a very difficult portion of the initial dissection. A synovial elevator is then inserted into this small opening, helping free the median nerve from this ligament. I then use my scissors to create a window. The synovial elevator is then inserted into the carpal tunnel, freeing the median nerve from the transcarpal ligament. This is a dilator. This is the smaller of the two dilators, which is inserted easily into the carpal tunnel, followed by the next size up. The endoscopic camera is then inserted into the wound. You'll notice on the upper left, this is the camera, and above you're seeing the transcarpal ligament. You can see the white fibers that actually look like a ligament. I'm tapping on the palm of the hand with my other hand, trying to find the edge of the ligament. You can see my hand tapping. These are the nerves that we're trying to protect. The blade is deployed and a small portion of the ligament is incised. I then work my way slowly back to the back edge of the ligament. Just beyond the edge of this ligament is structures that we definitely don't want to cut. So I take my time working my way back. Finish the cut. Look around one more time and make sure everything is completely divided. Still feel like there's a few fibers right there that need to be cut. There's one edge of the ligament, there's the other. There seems to be one small band still remaining. Now it's released. Re-inspect the whole carpal tunnel. And the entire transcarpal ligament has been divided. and then insert my scissors just into the first part of the carpal tunnel and push the ligament edges apart. We then have to go back and cut the portion of this ligament going the other direction, and I do this to a length of about 2 centimeters under direct visualization with my scissors. I use one of the carpal tunnel dilators to dilate above and below the ligament, and I leave it in to protect the nerve immediately below and start the division with my scalpel. The dilator is then removed, and I can better visualize the proximal portion of the ligament. Using a push technique, I divide this to a length of 2 centimeters and visually confirm that it's opened up. The wound is then irrigated with saline. I place an IV catheter into the wound and watch the tip of this so that it doesn't injure the nerve. This is so that I can put in some numbing medicine after the end of the surgery, so that when the patient wakes up, their surgical area is nice and numb. I then do a buried closure. These are dissolvable sutures that do not need to be taken out. Usually 2 to 3 sutures are placed. This ends up being a very nice closure, and it's nice for the patient to not have to have any stitches taken out. This is Mastisol. It's really a skin glue. It's not to glue the incision together, but more to help hold the adhesive bandages down, to protect from sweating, etc. A steri-strip is placed over the surgical incision. This supports the wound as it's healing. A small piece of gauze for the final dressing, and a tegaderm. This is a waterproof dressing that I put on so that patients' wounds are protected in case they get their hands wet accidentally. And this comes off after 4 days. Local anesthetic is then inserted through the IV catheter previously placed. This allows the patient's hand to be nice and numb when they wake up. A Coban wrapping is then placed over this bandage. There's no splint used, and the patient can start using their hand today. We're finished, and thanks for watching.